Good afternoon, everybody. Welcome to this meeting of the Leicestershire Health and Wellbeing Board. For those of you that don't know, I'm Michael Squires. I'm the chairman of this board and also the Cabinet Member for Health at Leicestershire County Council. This meeting is being broadcast live via YouTube and it will be archived so you can view it afterwards. Please turn your microphone on when speaking and turn it off afterwards. We've received apologies from Jane Moore, Director of Children and Families. Oh, and also from Councillor Abbott as well. Next, agenda item 1 is the minutes, pages 3 to 12. I propose that the minutes of the meeting held on the 29th of May 2025 are taken as read, confirmed and signed. Do I have a seconder? Yep, everybody agreed? Yep, thank you very much. Agenda item 2, urgent items. There are no urgent items. Agenda item number 3 is declarations of interest. I have a declaration myself as I have a standing interest in all substantive agenda items due to my employment with LPT. After reviewing the items, I don't think they're sufficient for me to need to leave the room. Does any of the members have any declarations they wish to make? So next we have my position statement. Copies of that have been emailed to you and a version is also published on the Council's website. So Mr. Carl Abbott CC is the new Leicestershire County Council Cabinet Lead Member for Adult Social Care, and therefore he becomes a member of the Health and Wellbeing Board, although I appreciate we have received his apologies today. Toby Sanders is the interim CTO of the LLR and Northamptonshire Cluster Integrated Care Board, and therefore he is taking up one of the ICB's non-clinical places on the board. Welcome, Toby. Hi. Pete Burnett, Chief Strategy Officer, is taking one of the other non-clinical ICB places on the board, along with Rachel Dewar. We await confirmation of who the new Integrated Care Board clinical representative of the board is going to be. Moving on to adult social care. The Care Quality Commission published a report on how the County Council undertakes its responsibilities under the Care Act 2014. The CQC assessed the Council as requires improvement. Whilst the outcome is disappointing, the Council notes that many positive comments and commitment noted by the CQC. Improvement activities already underway to address issues highlighted by CQC. Adult social care services continue to face high demand with increasing complexity of presentations for all elements of service delivery, including Care Act, occupational therapy, Mental Health Act assessments, and services for young adults with a disability. Moving. Okay, just take it to engagement then. Okay, moving on to chair engagement. Over the past 4 months, I've been getting familiar with my role as Cabinet Lead Member for Health, taking part in numerous introductions with partners across the system, place and neighbourhood. These meetings have provided useful insights into the depth and breadth of work taking place across the county of Leicestershire. And I've been impressed by the quality and dedication of contributions from all partners to enhance the well-being of our local communities. I've also actively taken part in a range of partnership and community engagement events and meetings, which aim to improve the health and well-being of our residents. Today, I have been presented with a petition in relation to the reopening and securing of St Mary's Birth Centre in Melton Mowbray. This is a unique service in our county and provides prenatal and postnatal services as well as inpatient births. Currently, the centre is closed due to staffing shortages. I'm already liaising with UHL regarding this matter. I will be reviewing the petition later today and will take account of all of its contacts with a view to maintaining the service. Do any members have any questions on the statement? No. Okay. So next agenda item is item 5. That's the NHS 10-year health plan. This report provides a summary of the main themes in the NHS 10-year plan for England, which was published in July. To present this report, we have Pete Burnett, Chief Strategy Officer, LLR ICB.
Thank you, Chair. So I'll take the paper as read, but we'll go through the kind of salient points that are encompassed in the 10-year plan. The 10-year plan, should say, started out, it builds on the back of the Lord Darcy review into the state of the NHS that took place this time last year and was published September last year. And the 10-year plan then builds on that and was published by the government in July, setting out their policy for the NHS and healthcare for the next 10 years. It focuses on three main kind of shifts as it sees within the plan. So one's around neighbourhood healthcare, one's around prevention, and the other one around digital, analog to digital. But with front and centre of that plan being the neighbourhood health care model and supporting patients in the community with their care. So that is the main thrust of it, but there are other elements going through it. So if we take onto the hospital to community section, that is around building neighbourhood health teams in our communities that can support patients with long-term conditions and prevent people turning up under an emergency or an urgent appointment at doctors and into secondary care, and actually by having kind of wraparound support for their kind of health needs. Initially, it's focused on reducing activity within our kind of secondary care providers, so our acute hospitals. But actually, as it grows in the plan, if you work through it, it then builds into voluntary sector support, employment support, and that's based around, in the future, it'll be based around neighbourhood health hubs. So in the first part of the plan, and that's in the kind of this current kind of phase of Parliament, there's an ambition to have around 45 to 50 neighbourhood health hubs in England, but by the end of the plan, they're looking to have up to 250 to 300 health hubs, which would have these kind of wraparound services built in. But the first emphasis is on the kind of health elements of it, but we're mindful of actually how we move that forward. And in Leicestershire, we're already moving forward on that, and in the west of the county, there already is part of a neighbourhood health pilot that NHS England run. Our intent was it to be across the whole county, but NHS England said that size was too large and reduced it down. So that's where we are at the moment. But there's already work taking place in this across LLR, to be fair, with the emphasis on kind of putting that wraparound support in for patients when they need it. The next element is on analog to digital. There's two parts on this. There's one which is very much patient facing, and there's the second bit which is very much within the kind of NHS and productivity piece. So the productivity piece is around using digital solutions and AI, for example, to free up clinicians' time. So writing letters, ambient voice technology, scanning, doing an initial scan on diagnostics to see if there's any issues, freeing up clinical teams' time so actually they can spend more time to care, not dictating letters and writing letters out, and that can be make us more productive and see more patients. The second one really is focused around how the public interact with the NHS and the use and the big emphasis on the use of the kind of app, the NHS app, and developing that. So allowing patients to be able to book appointments rather than receive letters saying when their booking's going to be able to interact with health clinicians for advice and support on their kind of healthcare needs. Also have a library of kind of health apps to help people kind of listen to, if they've got a health condition, actually how they might kind of look after themselves in the community by using a range of health apps. There's a real emphasis on going into the app, but there's also acknowledgement that not everyone's going to have an app. There's issues around connectivity, there's issues around smartphone. So just to be clear, it's not saying everything's going to go that way, but clearly as society becomes more digitally enabled, there's an emphasis on using those tools to free up people and give them more ownership on their health. And also within that, there's an element of that kind of experience and being able to feedback on the experience of healthcare they've had. And the final one is around prevention. I would say in the plan, it's not as ambitious as it probably needs to be. And I'm sure Mike would agree with on this one. If you look at the health of our population, actually we're lagging behind most modern countries in terms of healthy life expectancy to have stalled, but it does look to tackle obesity, mental health, and certainly mental health in schools, elements on alcohol misuse, and also kind of smokeless generation, which is a good key steps, but I think there's probably more to do in that regard. So that's the crux of the 10-year plan. There are other elements in it. So there are the changes that we've seen across the infrastructure of the NHS and how we're organised. So the ICBs clustering or merging in some areas of the country. Talk what happens to the integrated care partnership meetings and Health Watch and different elements that came out of the 10-year plans. There's structural change. There's a focus on quality with a National Quality Board to kind of focus in on kind of quality of care. There's a workforce section with the expectation in the coming weeks there will be a new national workforce plan, which is more about skill set than it will be about growing numbers, because it was used to it. There has been published a workforce plan by the previous government. And then finally, there's looking at financial flows around the NHS and how that kind of operates. So what isn't come out as in that presentation, if you read it, but actually is in there, is about that patient experience element. So there is an emphasis in the plan on using the feedback we get through the digital solutions we have, also allowing patients to determine what I'm not sure this hasn't been worked out, but how much a provider should be paid for the service they've had. There's clearly a lot more work to do in that, but there is an emphasis in there on that patient experience. So that doesn't come through as you read it, but actually read through the different sections. It doesn't come through as a separate section. If you read through it, it's clearly a silver thread that works throughout it. The key emphasis, though, clearly is bringing the NHS back up to delivering its core constitutional standards and living within the financial envelope we are provided from the government. So that's the core crux of the shift and what we're trying to do by providing care in the right setting at the right time. Happy to take any questions.
Thank you. Yes, I will now open the floor to any questions. Yes, Fiona Barber, please. I think you've turned your microphone off. There we go.
5, 4, 3, 2. Right. Okay. Fiona Barber from Health Watch Leicester, Leicestershire. Thanks very much for sharing with us the outline of the 10-year plan. I think most people would say fantastic. You know, it sounds absolutely marvellous, and would look very much to see the improvements that we think it's going to generate. And the three areas, from hospital to community and analog to digital and sickness to prevention, are all really sound, aren't they? And I think we'd all welcome progress being made in all of those fields. I think from a Health Watch perspective, one of the key issues for us is how you can, as you start thinking about how to deliver this, is how you bring in the communities to actually make this work, because that's going to be a key element of actually shaping and making things consumer friendly, for want of a better way of describing it, I suppose, because you touched very briefly on, for example, the digital side. That's going to be a really key issue for many people in our communities, not because, you know, the old theory that old people don't know how to access digital has gone out the window now. Now it's more likely to be you can't connect, you haven't got the right equipment, perhaps the language isn't there, confidentiality if you just got one piece of equipment shared throughout a family, all those kind of issues. All those need working through eventually. But if you are bringing people in the communities in to work with you, then I think we will actually find that we've got something which works for everybody and they'll buy in. It's a bit like the prevention side, I guess. You know, if we want to think about prevention, then one of the key elements has got to be around community resilience. If you make us all feel better about who we are, where we are, what we're doing, then generally speaking, our health will reflect that and hopefully have less demand on NHS services. And of course, community resilience features quite highly within the Health and Wellbeing Board strategic development in the new version that's coming through. So I'm hoping that we can get all partners to tie these elements together, so we're not working in silo and coming up with different answers to the same question. And like I say, Health Watch is picking up from people that they look forward to the changes, but want to be part of how it's going to look coming down the line. Thanks, Chair.
Thank you. Are there any further questions? Yes, Toby, go ahead.
Less a question and more a couple of comments, if I may, Chair, if that's okay. I'm very mindful that today's my first attendance in this forum, and my general rule of turning up at meetings for the first time is to listen more than you speak, which I shall do. But I just felt on this item it was worth just adding a couple of points to Pete's helpful overview. It kind of builds on something Fiona was saying. From my perspective, there's an awful lot to like in the 10-year plan. You kind of look at it and there's very few things probably in there that most of us would disagree with. There's questions about access and equity and making sure that we've got the digital agenda in a way that people can engage with. But in broad terms, what it sets out in terms of those shifts is the kind of stuff we've been talking about across health and care, probably for an awful lot of many of our careers in this room in terms of those focus and shift areas. So for me, the crucial question is, so what's going to be different this time then in terms of actually moving on with that? And I think that's where, Pete, you referenced some of the changes in the way that we work and the way that not just the NHS works, but from my perspective, the way we work with other partners around this table in particular, local government, voluntary sector, patient groups and other organisations. And I really welcome the opportunity over the coming months as we reshape the way and the role of the integrated care boards across Leicester, Leicestershire and Rutland, and also working in partnership with Northamptonshire, which is our direction. We've been given a very clear ask by government to make a really significant reduction in our running costs of about a third. That's about £16 million saving on the staff, buildings and tech, not healthcare services, but the way that we run our organisation. So we are going to look and feel different as an integrated care board and the way we work as a cluster. But in doing that, perhaps the most important thing for me is how we work at a neighbourhood level and at a place level with our partners in our 5 places that we now have across that wider cluster geography. And therefore this forum for me is really important and central to the way that we do that and keep that focus on our local populations, our places and their particular health needs. So I can see several things threaded through today's agenda that kind of link into this space in terms of health and wellbeing strategy and so on. But looking forward to the opportunity to work with colleagues around this table in terms of how we challenge ourselves to respond to the 10-year plan, deliver with some of the challenges that all of us are facing, particularly in terms of wider public sector financial climate, and actually lead ourselves in the way that we work together to something different. Thank you.
Thank you. It's a great comment. I've got a question here. I've written mine down, unfortunately, but it's setting out essentially national ambitions and interpreting them locally. Across Leicestershire, we're struggling with workforce retention and staffing shortages. So how confident are you that the plan matches resource to ambition?
So well, I think that's part of the point of the workforce plan that the government will publish, and I understand in the coming weeks. So it's not necessarily about numbers, it's around the actual skill set that you have in your workforce. It's clearly they're under pressure at the moment in time, but actually it's about shifting that resource to the right area for the care to be taking place at the right point. And that's the key, isn't it? It's around actually if you can do more wraparound supportive care. And once you escalate into a more acute episodes of care, you need more staff to look after those people. So the more we can care for people in a more proactive way out in the community to keep their needs and stop them escalating up in a health element, that should reduce the number of staff you need to do that. So, but it's not necessarily about reducing our total numbers, about actually saying where the resource is, because you're right, I think we're under pressure on our workforce, and our workforce does feel stretched across the sector in terms of what it's doing. So if you can reduce people from escalating up, then you'll reduce the amount of healthcare workers you need. But I'm not necessarily saying that's going to be shift. We'll have to work through the plan, and those pressures will probably still remain. But the shift itself should help in that with that intent.
Okay, thank you. Any other comments or questions? Yes, Simon.
Check if I'm on. Can you hear me? Fantastic. Pleasure to meet you. We've not met before. My name is Simon Pizzi. I'm the Associate Director of Strategy and Partnerships at University Hospitals of Leicester, and I'll be the permanent member from UHL at this group. Building on Pete's point, I think the 10-year plan really directs us towards a strategic shift in how we think about provision of healthcare services. In many of our services at UHL, we haven't changed the model of care since the foundation of the NHS in 1948. This is a wholesale shift. If we carry on the way we are, though, we will ever be growing our reliance on international recruitment, on expanding provision in universities for staffing groups, be it nursing or medical. That will probably become unaffordable if we don't change the way we work. And the 10-year plan really directs us towards a shift in how we provide our services outside of our acute hospitals into the community to prevent that growth requirement that the country's struggling to fulfill. So I think we do have to focus on retention, and UHL has a RISE programme which really focuses on making sure we have the right equipment, the right support for our staff, and making our staff enjoy working at UHL as much as possible and want to stay at our organisation. And retention rates and turnover rates are currently at the lowest. So turnover rates are the lowest we've seen in UHL in the last 15 to 20 years. So there is evidence of our changes that we're making are leading to improvements for staff. That coupled along with the strategic ambition of the 10-year plan about bringing care outside into the community and preventing the need to grow, I think will result in better care for our patients. Thanks.
Thank you. Yes, please go ahead.
Yeah, thank you, Chair. Ed DeCovley. I'm the Chief Executive at Melton Borough Council, here representing district councils this afternoon, but also the joint chair with Mike of the Staying Healthy Partnership. Really welcome the discussion, really welcome the focus. Like colleagues have said, I think the 10-year plan gives us real opportunity. I think just a couple of practical considerations if I can. So it's great that we are the pilot or have a pilot opportunity on the west of Leicestershire. I'm not aware of what kind of broader engagement there is at the moment in relation to the partners involved. So I'm thinking from district council perspectives and some of the local networks that my colleagues on the west of Leicestershire will have. Just want to make sure we're connected in with those. I'm happy to have a conversation separately on that. And I suppose just a broader point around the direction of travel for ICBs generally. Obviously, you referred to the clustering of ICBs at a broader scale. We obviously have local government reorganisation, which is scaling up as well. So I guess it's just making the point and looking for some collective assurance around the continued focus on neighbourhoods, because we know that's where the difference is made at that kind of level of geography. So as we scale up our structures, how do we make sure that we continue to commit at that localised level? So I suspect this discussion could go on for the ages, but it's one that would be good just to get a couple of reflections on, Chair, if that's okay. Thank you.
Yeah, I'll come back on that point. So whilst the national pilot is very much focusing on West Leicestershire, we've made an absolute commitment that this is something that we're rolling out across Leicester, Leicestershire and Northamptonshire. And we're making absolute commitment across all of our 5 places that the learning that we get from the national programme will very quickly be cascaded amongst those other areas. Our local coach for the pilot scheme is very much committed and has already spoken to East Leicestershire about his commitment to work with them equally and to make sure that they're involved. We had a conversation this morning at the neighbourhood board. We've also, given the pace of conversation, we're setting up a separate neighbourhood group within the county. And Ed, you should have received an invitation. If you haven't, it's on its way to you to be part of that, so that we can make sure that both the Staying Healthy Partnership and the Integrated Delivery and Commissioning Group and all of our partners, including Healthwatch and Voluntary Action, are involved in those conversations, so we can really start to put some meat on the bones of those plans happening locally.
Thank you. Any further comments or questions? No. Okay. So I will propose that the information provided in the report be noted and priority actions be supported. Do I have a seconder? Okay. Okay. So agenda item number 6 is the Families First Reform Programme. This report is about the delivery mechanism for the government's reform of children's social care services. Ellie Lowe, Head of Service, Families First Partnership Programme, will present this report.
I'm just going to give you a brief overview of the programme. Hopefully you all have had a chance to read the paper. So Families First Partnership Programme is the delivery mechanism of the government's reform of children's social care. It's quite a wide spanning programme. It's obviously of a multi-agency nature. So We've set up some governance for the delivery of this programme across the county, and we've set up a Reforms Implementation Board, which is a multi-agency board, and it's chaired by the Director of Children's Services, Jane Moore, and it includes representatives from the ICB, LPT, Public Health, Police, Education and Adult Social Care. And the purpose of that board is to provide strategic direction to the programme, as always, as also being the decision maker. Sitting within the governance structure, we also have a core steering group. This is a check and challenge group, and it's chaired by the Assistant Director of Social Care, Sharon Cook, and includes representatives from education and across social care and business partners. And our mechanism for delivering this change programme is through a series of change groups. So the national programme has a great emphasis on multi-agency safeguarding arrangements, on integrated support and help to families when they need it, and also some key areas around family group decision making for families who are in pre-proceedings. So these change groups are focused on those three areas. We're really fortunate to have seconded to us a police officer, a designated health professional and colleagues from education services. So they sit on these change groups alongside colleagues from social care, including practitioners and managers. So if I start with the first of the change areas, family help. So that is around bringing together, integrating the targeted family help offer, or targeted early help as it's sometimes referred to, alongside child in need services. So this is really having a focus on families who need help quite early. They need a targeted and integrated support. And what it's enabling us to do is have a more seamless transition for families who move from targeted early help to child in need services. Fortunately, in Leicestershire, we rolled out this area of work back in 2024. So although the government requirement has only been shared with us more recently, we're actually quite well ahead in Leicestershire in delivering family help and already have in place an integrated model. So what this means in practice is that our alternatively qualified staff in targeted family help are able to support families through to child in need with social work oversight. We have found much improved outcomes for families who are now receiving intensive family support throughout child in need. And we have a good record of prompt closure of cases where it's appropriate and better outcomes for families. Also within family help, we're having a look at our multi-agency arrangements for Team Around the Family. So whilst integrated targeted family help and family help is working well in localities, we know that we're not always consistent in achieving the multi-agency arrangements for Team Around the Family. I think is often the case in locality arrangements. Many ways of working are built on relationships, and it's looking more at how we make things embedded in systems and processes. Family group decision making is another of the government's key areas for development, and within the Children's Wellbeing and Schools Bill, it will become a statutory requirement for us to make an offer of family group decision making at the point a family enters into pre-proceedings. We want to be more ambitious in Leicestershire and move towards consistent use of family network meetings. So the idea of a family network meeting is ensuring that the child and family are absolutely involved, but also their extended network, which may be family and close friends, and looking at the role of those extended networks in the community in supporting families to stay safe and for children to stay with their family and extended family relationships. It's likely that we would look at some particular additional support at pre-proceedings, but otherwise it will become part of our core practice. The third area in the reforms is around multi-agency child protection teams, and this is looking at developing centres of excellence for making decisions and oversight of child protection arrangements. The timeline for this reforms programme, we expect to have implemented some elements of it by April 2026, but this is an ongoing programme and we expect further developments to continue through to 2028. The recommendations that were made to the board were to note the contents of the paper and for individual agencies to consider the implications and impact of the change and reforms that are contained within the paper for their own organisations. We have got various stakeholder engagement plans in place, which includes briefings for partners, partnership conference, and of course we're working with children and families to ensure their views are fully incorporated in the changes that we make. So happy to take any questions.
Thank you very much. I will open the floor to questions or comments. I think it was Rachel first and then Councillor Pugsley.
Oh yeah, really great work that's happening, and I think it's really important work. Jane Moore is part of the Neighbourhood Place group for County, and I would just suggest that it's really important that we have this work aligned, particularly in terms of the Families First work and making sure that we have a really strong alignment with the neighbourhood work and this piece of work.
Thank you, Councillor Pugsley.
Thank you, Mr. Chairman. As lead member for the department, it's really exciting for me to be able to sit here and say that the Children and Family Services Department have had a really strong start to the partnership. I think we've had excellent engagement across the partnership, which is really good when this work is so crucial. I think as lead member, the most important thing to me is to all of us is that we're delivering really good outcomes for our children and families. So it's really important to see such good work on the partnership to ensure that we're getting the right help in at the right time for our families. Thank you, Chair.
Thank you. Fiona, please.
Thanks, Chair. I think I must be getting a little bit old because I remember a lot of the stuff from supporting families some years ago. And the supporting families worked well in part, mostly because it had that real good hub of different partners putting their heads together to come up with a plan working with the families. And I think perhaps the reassurance that people and communities would like to see is that this is a whole partner approach. So I'm going to bang Kevin's drum and go for add the voluntary sector and education as key elements for part of this, because they bring so much to the table and part of the work that's going to be done or is already being done, I think. And the other thing, the councillor mentioned outcomes for children and families, and that's really key. But of course, outcomes for children and families can be viewed very differently depending on which side of the table you're sat on, whether you're a professional or you're a member of the family and that particular child. So it's reassuring, I think, to hear that you're involving families and children in actually thinking about what kind of things might be outcomes. And I'd be really interested to know what success is going to look like at the end of all of this. Is it better attendance at school? Is it people saying that they feel better? And what exactly will families and children benefit from, or how? That's sort of what I mean, I think. I think I know what I mean anyway. Thanks.
Thank you. So just hopefully some reassurance. We are involving the voluntary and community sector in the programme, as well as a broad range of partners, and see that as absolutely essential. I think there's some real parallels to be drawn with the 10-year plan and the neighbourhood work. Sitting behind the family networks, which we see as really fundamental to improvement, is the idea, a favourite phrase of mine is, it takes a village to raise a child. And it's really building on that notion of building a sense of community and network, which is not always about family. Sometimes it goes much broader. And I know particularly our partners in the voluntary sector have a key role there to help build networks for families who find that they don't really have many. Education have an absolutely key role. So obviously education services within the County Council are very much involved. We are planning a conference for all schools in Leicestershire to be able to have their say, which is being called the Big Conversation. And I will be spending a morning with all of those schools, so they're able to tell me where they feel there are improvements to be made and to share their ideas with me. In terms of outcomes for families, we're working towards a theory of change and hoping to really find out from families. So our first range of events is over October half term for all families to come to. We'll be doing some craft-based activities with them to share their ideas. And we're looking at everything from the language that we use, so terminology like words like assessment, how that feels to families, through to how they would like to be looking at goal setting and looking at their own outcomes. So it is a very substantial piece of work, but at every level, we hope to ensure that we've got the voice of children, young people and families included.
Thank you. Mike Sands, please.
Yeah, thanks, Chair, and thanks, Ellie. I should know the answer to this. Is it worthwhile just kind of taking us through the difference but the similarity between family hubs and families first? So my answer would be families hubs are universal, but families first is more integrated working, you know, as you were saying, kind of targeted early help in the children in need. Have I got that right? And I suppose it'd be interesting to know just how the two overlap and work together.
Yes, that is a good summary, Mike. So Family Hubs does incorporate our universal offer, but it's also a mechanism for our multi-agency working. So we have 21 family hubs around the county and lots of our partners use them. So they're used by midwives, by health visitors, and all ranges of services are delivered from them. So they've become an actual one-stop shop which families can visit. We also have a digital offer with family hubs, which includes a website. And I'm sorry, I could probably talk for way too long about this as it's an area of interest for me, but lots of joined up work with, for example, libraries and going out on the library bus to do outreach. So that sits very firmly with the Families First Partnership Programme, because again, it brings in that sense of building community and building access to services. One of the things, as I mentioned, we want to achieve is around our use of language, but also around transparency and understanding of our services, our systems and our processes for families, so they understand what is available to them. So again, Families First and Family Hubs really tie together on that. I think it's fair to say, though, that the main point of Families First Partnership Programme is the beyond universal services, so when we get to targeted support, but we can't do that without thinking about universal and early help.
To come back on that, because I think that's the point Rachel made, and again there is something about the way you've described it, that digital and then the universal access and then the kind of targeted early help and the work together. I suppose that's the other bit. Can take that forward, that way of thinking, into the neighbourhood health service model. I was just writing down in my mind, though, as a health and wellbeing board, I suppose, well, maybe it's just me, getting my head around everything that's going on, because then you've got Families Hub, digital offer, Families First, you've got neighbourhood health service model, probably working on those three levels. Stick in place women's health hubs, then you've got the district support offer as well and county council support offer. Just want to make certain we don't end up with 15 hubs and 16 spokes per kind of district. So it's probably an interesting conversation to be had when we're going through the neighbourhood health service model about how we make certain we're maximising the use of physical and people assets as we develop
it. Thank you. Any further questions or comments? Okay. So I will propose that the board notes the contents of the report and shares within agencies, participates in partnership briefings and engagement events to support partnership collaboration, considers the implications for practice, process, future commissioning. Do I have a second, please? All in agreement? Thank you. So agenda item number 7, this is the pharmaceutical needs assessment. Pages 41 to 166. This report informs the outcome of the statutory consultation on the draft Pharmaceutical Needs Assessment 2025 and seeks approval of the final P&A for submission and publication. This report will be introduced by Hannah Blackledge, Public Health Intelligence Lead, Leicestershire County Council.
Thank you, Chair. I also would like to welcome our pharmacy commissioning representatives, Paul Gilbert for the ICB and Diane Wells and Vanessa Hales for NHS East Midlands primary care team, who probably will be more in place to answer any future commissioning questions on the report. Moving on to the report, the board will recall it considered the contents of the P&A, the P&A and approved draft for the statutory consultation on the 29th of May, a so-called pre-consultation draft. The purpose of the report today is to, first of all, update the board on the outcome of the statutory consultation, on any amendments that has been, the amendments to be approved to pre-consultation drafts, and the resulting final conclusions and recommendations of this final draft. And we'll be also asking the board to approve the final draft for publication on the 1st of October 25. I'm taking that policy background as read. The very quick reminder is that P&A is a statutory document, is produced every 3 years by the Health and Wellbeing Board, is in accordance with the national guidance, and is overseen by a multidisciplinary P&A reference group or steering group, which is LLR wide. So the 3 P&As for LLR are produced concurrently. The board report includes some links and references to the main regulation and guidance for those who are interested. Moving on to the progress since the May, this pre-consultation draft. So we've included all the comments and suggestions from the last board in the draft. The statutory consultation took place from the beginning of June to the 10th of August. A 60-day consultation process, including all the consultees as required by the national guidance. And that survey was also open to the public. We have received 22 responses. The majority of them went to online survey, but there was also a written response by the ICB, and that's included in your pack as Appendix B, page 165. That's a full response from the ICB. The board paper, paragraphs 20 to 24, again, I take them as read, but I will summarize quickly what was involved. So the outcomes of the consultation generally was that the P&A, the respondents, P&A was considered comprehensive and clear. The majority of these questions are about the coverage of the P&A and whether it fits the purpose. So there was generally a good agreement with P&A conclusions and recommendations. We didn't have anybody who disagreed with anything. There were a number of suggestions for refinement for the future rounds of the P&As, including more focus on and forward planning, stronger stakeholder engagement, and also embedding some service evaluation within the P&A document. The ICB response was broadly supportive of the P&A's conclusions and recommendations, again highlighting the role of pharmacies, that the pharmacies can play in tackling health inequalities and advocating the inclusion of pharmacies in the local core 25+5 strategies. The way it's seen that there are 5 main areas of emphasis. The first one is integration with primary care and other healthcare partners, innovative service delivery, mainly through additional services, enhancing the additional services that can relieve the pressure on other parts of the system, tackling introduction of new technologies, both for the users of the service and the digital integration of pharmacies themselves in wider services. The other area of focus was promoting public health role of pharmacies to support life course priorities, so health promotion and public health, And the fifth one is planning for growth, particularly a regular review of provision in view of ever growing housing developments. So we also, apart from the consultation, we also have some additional results from the 2 surveys that were conducted earlier in the year and extended through the summer. One was a professional survey and one was for the public. And the public survey, which is summarised in paragraph 19 of the board report, basically, it must be stressed that there was a generally an overall very good level of satisfaction with the service. There were some suggestions around basically monitoring the accessibility areas to the pharmacies, things like practical things like accessibility for the disabled, parking spaces. So a lot of these are basically for the review in the commissioning process. And the paragraph 18 it summarises in your report also some additional issues identified through the professional survey as well. And these are mainly around workforce capacity. The other changes to the report include we've updated some demographics with the brand new population projections, which are important. We've added the whole section on the housing growth, and thanks here go to the strategic planning team of the County Council for compiling these figures. And also there is a lot of information from the neighbouring health and wellbeing board areas, which are important for the county. Their P&A process basically and now also is in a similar stage to ours. The conclusions, these are covered in paragraph 26 to 34 of the board report. These are in brief. Again, I'll take it as read, but there is there's basically there is several statements there which are required by the guidance on each type of service, whether it's sufficient currently or what are the potential future problems with it. But there's generally, it has been concluded that there is sufficient overall pharmacy provision at present, but there's a need to keep this under review, especially for the new housing growth areas. There is one of the conclusions is about the increased service demands to do with population growth and also expanded services and enhanced services. And the need to support the continued growing role of pharmacies in the wider care offer in healthcare, not just primary care but urgent care as well. So there are some areas of focus emerging from this public and professional engagement. These are probably can be summarized in a lot of them are around accessibility. So as I've sort of mentioned before, disabled access, parking facilities, public transport to be probably more regularly reviewed, and evening and weekend access opening times may be changing over time. So and also from the professional engagement, again, workforce capacity emerged as a sort of common theme. The recommendations are summarised in paragraph 35 of the board report, and again, just drawing a few top points are effective planning for growth in those areas that are particularly prone to big population growth in the next few years: Charnwood, Melton, North West Leicestershire. But not only, and making sure that there is matching provision in these areas, support for integration with other of pharmaceutical services with wider health systems. That would include digital enablement. and supporting the promotion of pharmacy's role and services related to public health, because in particularly in the public survey, there are figures indicating, although people are quite aware of additional services, but it's the public health side that probably needs a little bit more promotion. And access issues, as I said, and we basically an important recommendation of this is that we are recommending periodical updates to the health and wellbeing boards on any important service changes, anything to do with workforce capacity, any policy and funding changes will need to be under review, particularly where the population is growing. Also transport provision and issues of equity, particularly rural equity here. So just the last word, thank you very much for involvement to our reference group, and to Mike for chairing it over the last year. I will be happy to answer any questions, and also ask my commissioning colleagues to ask questions that are more relevant to future commissioning. Thank you.
Okay, I will open up the floor for any questions or comments from anyone. Okay. Oh, yes, Fiona, go ahead.
Thanks, Chair. Until very recently, I was a lay member with the General Pharmaceutical Council, so I had some input around particularly the education and assessment of undergrads and the extension of the pharmacy role. So one of the things that I think is important to think about is also, I know Healthwatch discussed housing and transport, but also the extension of the skill sets for people within pharmacies. So that's pharmacy technicians, as also pharmacists, because within the next 2 years, all undergrad pharmacy students will be coming out as independent prescribers. And that will lead to an extension, quite possibly, of the roles and the remits that will be available to for them to deliver within communities. And that fits in with the bigger thinking, I think, around the PNA. And the other thing in terms of the housing development and development per se is linking it to the local plans at district level. I don't know, Ed, whether the plans, for example, at Melton are cross-referenced with the PNA, but that would provide a clear line between the PNA is trying to do and the future development that's out at district level, because I think districts are planning sort of 10, 15 years in advance now for some of the major housing stuff, and that's quite key. So that would be a good link to make, I think. Thanks, Chair.
Yes, there is the housing section contains quite a lot of sort of quite up to date, because things were, as we were writing it, the sort of latest figures came in quite late, and they as we were told, is the sort of the most up to date in terms of numbers per district, and also there's basically a heat map there showing where these main developments are, so should form a good basis for planning, hopefully. Thank you.
Toby Sanders, please.
Yeah, thank you, Chair. A comment rather than a question. Just wanted to be really clear on the helpful to have seen the ICB's letter appended within the paperwork. Just to be clear, that's a letter that's a yes, supportive and type of a letter rather than anything other than that, just to make sure that was clear for the notes. And in particular, from the point of view, PNAs are a very particular technical kind of a thing, aren't they? They love them over the years, and they're going to have to set and answer a very specific set of questions, and this clearly does that and does that very well. But in addition to that, the paperwork also rightly points to the much broader role that community pharmacy now plays across our health and care systems up and down the country. And that's something that we're absolutely keen to continue to support and to see develop. We often rightly focus on the role of general practice and access to general practice, but actually access to community pharmacy on a whole range of broader areas is now so much more of a thing. And I think the PNAs still obviously have that core focus in answering those technical questions around access and coverage and geography and so on and future pipeline, but really just wanted to kind of emphasise what you did draw out, Hannah, in terms of that future development potential in terms of broader scope of service provision, access opportunities. And I'd certainly echo your point that whilst the paper does reference the kind of a level of awareness of most users around those other services, I think there's more that we could all do collectively across our different agencies to continue to raise awareness, because I know when I talk to people who live locally, to staff, to family and others, that they often have very different levels of understanding of what you can access and kind of gain through. So we're obviously doing work on that front from a health perspective, but keen to work with other partners through your own kind of comms channels on that front as well. Thank you.
Okay, doesn't look like there's any further questions, so I will propose that the board notes the report, outcome of the statutory consultation and amendments made to the draft PNA as a result, and approves the final attached Leicestershire PNA to be submitted and published. So I have a seconder. Thank you. All in agreement? Excellent. Item 8 on the agenda is the Joint Local Health and Wellbeing Strategy Review, pages 167 to 216. This report seeks approval for recommended changes to the current GLHWS arising from a review which has taken place. This report will be presented by Josh Namavji, Assistant Director of Public Health, and Abby Vaughan, Health and Wellbeing Board Manager.
I will get used to this one day. So good afternoon, everybody. I'm just going to share a short presentation to accompany the report. So just bear with me while I get that on screen. Yes, it is. Okay, so I'm going to provide you with an update on the Joint Local Health and Wellbeing Strategy Review, and the report can be found in your pack, pages 167 through to 216. So firstly, we'd like to take this opportunity to thank all partners for their contributions to this process, and this presentation will hopefully demonstrate how the information that's been provided by all of our partners and colleagues will inform and how well-attended workshops, may I say, have enabled us to develop the proposals to the changes to the strategy. So the purpose really of this presentation is to provide you all with an update on those recommended changes of this light touch review and the recommended approach and timeline for phase 2 of the project, which we are seeking approval from board to take forward. So the current 10-year strategy was launched back in 2022 and comprises of 4 strategic life course priorities, 3 cross-cutting strategic priorities, 10 sub-priorities and 80 commitments. And it was the 80 commitments that were agreed to be the main focus of this review. So just a little background regarding the strategy and the previous decisions that have been made. So the current 10-year strategy was approved by Health and Wellbeing Board in February 2022 and agreed that a review would take place every 3 years, which is why we're here now. At Health and Wellbeing Board, a development session back in 2023, it was agreed that the life course approach was the right approach to take, as it also aligns with our other partners' strategies. So the review of that approach was agreed to be out of scope of the review. However, as mentioned, it was agreed the 80 commitments would be the main focus of the review and also the cross-cutting priorities within the strategy. I won't spend too much time on this slide because you've already seen it before and it's a bit busy, but that just demonstrates the scope of the review. As you can see, the 80 commitments below the life course priorities on the bottom line, and to your right are the cross-cutting priorities that we've spent our time reviewing over the summer.
So the purpose of the review was to ensure that the strategy remained relevant in addressing current and emerging health and wellbeing priorities across Leicestershire, to evaluate the current commitments using the latest data and key evidence to identify which still remained appropriate, and to evaluate the cross-cutting priorities to assess their relevance and provide an opportunity to amend or to introduce any new priorities. And also to provide value insights to guide both ongoing activities for our subgroups and Health and Wellbeing Board and the development of future work for each subgroup, and to provide more targeted focus. So the approach of the review was commenced in February of this year, following Health and Wellbeing Board approval in February of that approach. The governance for this review has been agile, with Health and Wellbeing Board providing the strategic oversight, but the process has been led by a steering group which is comprised of a diverse mix of representation across system, place and neighbourhood. A review took place across all subgroups that sit underneath the Health and Wellbeing Board to deliver our current strategy and who are responsible for the life course priorities. And this happened during May and June, with good representation of all partners and other stakeholders either responsible for delivering the strategic priorities or impacted by the strategy itself. We produced bespoke data packs with our BI colleagues across our organisations, and each subgroup had information containing the latest joint needs assessment data and indicators for Leicestershire and other relevant data such as recommendations from JSNAs. And this provided useful a current tool really to assist with the decision-making process and provide that evidence-based approach for this change. So in terms of the recommendations, the conclusions, the key themes that were identified across all of our subgroups when reviewing the commitments, to provide that rationale whether the commitments should either stay within the strategy, be removed, or repurposed, I should say, really, and you'll understand that more as I move on, or transfer into another sub-priority. And what was fed back to us really was they contained a mix, the current commitments contained a mix of either actions, success measures or high-level visions rather than clear and consistent statements, making some of the existing commitments quite difficult to manage and track effectively. Some of the commitments were outdated since 2022 and referenced strategies or documents that were no longer in use. There was duplication that existed across several commitments that reduced clarity and focus and made it difficult to manage and track changes appropriately, and also to report. We found that officers were reporting the same information back and impact on a couple or more commitments. Some commitments overlapped or were more appropriately aligned to broader cross-cutting priorities. And data and insights also highlighted emerging needs, demonstrating that the new commitments needed adding or existing ones refining to reflect the current challenges and opportunities that were presented in the data packs. And again, some commitments are too broad or high level, making it challenging to define concrete actions and align them with success measures capable of demonstrating meaningful impacts on health and wellbeing. And also within the strategy, you may have noticed the commitments were presented as a long list, and it was difficult to identify the specific focus within each of the priority areas. Have you got anything to add to that one? Okay, so our main conclusions are that the majority of the strategy, you'll be pleased to hear, does remain relevant and fit for purpose, and it is a 10-year strategy, but there is refinement that is required across all the life course priority commitments to enhance that clarity, focus and effectiveness. Certain components will be much better framed as commitments reflecting core values and long-term priorities, while others may now sit better in delivery plans or action plans that will need further development. And others may sit better in departmental strategies as their own BAU. Additionally, some sit more appropriately as success measures rather than commitments to monitor and support that evaluation and measure impact. And this realignment will ensure the strategy remains focused, actionable and responsive to evidence and evolving context. And it will add that degree of flexibility as well, which we've not had in the previous strategy, with some of the commitments being so focused on particular areas. So, going to provide, where was I? So this is an example for you. So each subgroup recommended changes to their commitments, and these can be found in the report pages 171 to 172, with further details provided in the appendices. So as an example, this slide shows the recommended areas of focus for the Staying Healthy Partnership, who are responsible for the Staying Healthy, Safe and Well Life course priority. So under the sub-priority Building Strong Foundations, it is proposed that there will be 5 commitments. For the commitment to healthy placemaking, draft wording has been suggested. So there's been draft wording for all these commitments, but that will be developed in the next phase of the review. That's the proposal. But under healthy placemaking, it was we will work together to shape healthy places and create strong, connected and resilient communities where everyone can thrive. So the current commitments under the example in blue, so that's in the current strategy, are proposed to be removed, as they will be framed now as actions within a delivery plan underneath that commitment, healthy placemaking. So we will work to develop active travel across Leicestershire, including a review of connected and walkable neighbourhoods, etc. Or we will work with planners and licensing officers to further build healthy environments. So if you can see the theme, that's why we've been having an overarching commitment with those actions that will sit underneath those.
Just to say, the purpose of going through that one is, I guess, the worry was when you see the appendix, it looks like we're removing quite a few commitments and it implies that they're not important. And the message we're trying to get across is that's not the case. What we were just trying to do was to group them and then have the delivery plans that focus on those core themes. So that was sort of the reason for going through that example.
Sure.
You finished,
Abby, or? Next slide,
right,
sorry.
okay,
So as mentioned previously, the cross-cutting themes were also in scope, and the proposed recommendations for the cross-cutting priorities are illustrated on this slide. So for improving health inequalities, it was agreed that this priority should be strengthened through an inclusion of an overarching commitment, and each subgroup develop its own tailored delivery plan to access specific health specific health inequalities within their specific population or area of focus. And COVID recovery, it was also collectively agreed that this should no longer be a standalone priority, as the context has evolved significantly since the height of the pandemic. So instead, the subgroups supported replacing this with a broader commitment focused on health protection. So I'm going to hand over to Joshna, because we did attend Health Overview and Scrutiny on the 3rd of September to provide the feedback from that meeting.
As part of the consultation on this, when the strategy was first developed 3 years ago, there was a comprehensive public consultation. And this time round, because we conducted what we could say a light touch review, but I think as partners probably around the table will agree, it was probably heavier than we anticipated. But I'm going to stick to it being a light touch review. So on this occasion, we used the insights from that coordinated approach through working closely with Healthwatch, Leicestershire and Voluntary Action Leicestershire. So we didn't conduct the full public consultation this time round on the basis that we saw this as a light touch review, and this approach was approved by this board at its meeting in December. We also presented, we also took the findings from the review work to our Health Overview Scrutiny Committee, And there was some feedback there that we're taking on board as part of the rewrite of the strategy. So the report includes some of that feedback. The key themes that came out was there was a concern on that loss of focus on key health issues, which is the bit I mentioned earlier about this fear of when those commitments are removed, it implied that they weren't important. So we provided reassurance to committee that they weren't being removed from the strategy, just more that they were going to form part of the delivery plan. There was another point raised around healthy ageing and that focus on supporting individuals with their health and well-being post-retirement. And we talked through the strategy being a life course approach and therefore spanning all ages, but also agreed that we'd strengthen the wording in the strategy when we take forward the findings from the review. And the last bit was the focus on, there was a perceived view of a lack of focus on the impact of sedentary lifestyles on health and well-being. So again, we did provide reassurance to the committee that there is that focus on physical activity, but also we talked about the mental health impacts of sedentary behaviour as well. So again, we'll strengthen that wording in the report if it's felt that it's not strong enough in there.
Thank you, Joshna. So the revised strategy would remain with the 4 strategic priorities that take the life course approach, remain with 3 cross-cutting strategic priorities, although COVID-19 would be removed and replaced with a health protection cross-cutting commitment. A reduction from 10 to 9 sub-priorities, and this was due to Dying Well agreeing that the review, if need, could be incorporated into another one of their sub-commitments, and reduce 80 commitments to approximately 24, which would make that more manageable for all subgroups to take forward. So the proposed next steps to the review, and to be led by the existing steering group, although the membership will be reviewed to ensure we have the right people around the table, would be to initiate the rewrite and redesign of the strategy based on the proposals we've mentioned today, update the equality impact assessment that was produced in 2022 and review to ensure that that's effective, to begin communication planning, develop requirements and start formulating delivery plans that will sit underneath this strategy, and development requirements for reporting dashboards so that we can measure impact and report it back to the Health and Wellbeing Board. And ongoing would be review of governance to include the steering group governance, as I mentioned, the subgroups themselves that sit below Health and Wellbeing Board, and look at the Health and Wellbeing Board governance as well. The next slide just provides a timeline. So we did attend HOSC on the 3rd of September. We're attending Health and Wellbeing Board today to seek approval. The aims for the strategy, the draft products to be available at Health and Wellbeing Board meeting on the 4th of December, and to initiate the work streams that sit under that with key milestones of beginning that comms and engagement work and stakeholder analysis, etc., and having those dashboards and delivery plan requirements as well to be approved at the meeting on the 4th of December. So we're asking board today to approve the recommended changes to the current strategy and approve the approach to the next phase of the review. Got any questions? Thank you.
I will open the floor to questions. Kevin Allen, please.
First of all, for me, I just want to say thank you, because I know Joshna said light touch. It wasn't. You did a hell of a lot more than just a light touch review on this, and I think, you know, you should be commended for what you've done here, and also thank you for sort of trying to, I suppose, like herd cats, for better or word, really trying to get us all to come together and actually try and have those discussions and meetings in the timescales that you had to develop. I think this looks great. I do hope that, you know, we can get it moved forward, obviously, to the second stage. But I think, as I know I've said to both of you before, I think for me what's more important when we do agree, whatever it now looks like, is how we then communicate that out to that person living out in the county about what does this mean for them. Because if not, we run the risk of having this strategy. We all know what it is. We all know roughly what we're trying to look towards, an impact. but does somebody on the street actually know this is what we're trying to achieve? This is how they might be able to access something. This is how they might be able to play a part in something. And I think we're missing a trick if we don't actually explain what the strategy is there for and how it's trying to help them. But I can't say thank you enough, no, because like I said, I know it's not been a light touch piece of work.
Thank you, Kevin. We have we're proposing a community comms and engagement workstream that will address that, but we also had some engagement prior to myself becoming in post, and it fed back how the public perceived the current strategy. And I think one of our aims is for the commitments to demonstrate what is within those priorities, because they're quite hidden at the moment, and ensuring that that language is universal as well.
Any other question? Oh, Rachel Jur, please.
Hi, thank you. More of a comment than a question. I would like to echo the appreciation. It's been an absolute honour to be part of this process. There's a couple of things that I really appreciate though about this, and I think the specificity of taking some of those commitments and making them very clear what the actions are has been a really positive piece of work, and it also makes, I think, the document much more accessible in terms of really understanding what is going to happen behind the elements of the kind of commitment that's been made. And also I really appreciate the link between this work and the neighbourhood work, and we've worked really hard at making sure that there's alignment in those commitments, so actually the process becomes one in terms of delivering the health elements and the care elements to this. So I think it's been a really positive piece of work. Thank you.
Yeah, thank you, Chair. A comment and then a question. The comment, I mean, there's clearly a load of really good work in here, and actually it makes an awful lot of sense. I think the priorities, the way they kind of distill down, really, really helpful. And Pete, you were talking earlier on about 10-year plan from an NHS perspective. Health organisations are currently being asked to produce their own local versions in response to the 10-year plan that set out kind of 3 to 5 year versions from an NHS perspective. And actually, for me, the building blocks of that should be the work that we already do collaboratively in partnership with other organisations in this room and in the other 4 health and wellbeing boards across that new cluster geography. So really, really helpful and really timely. The question, it kind of builds on Rachel's point about impact. I can see the priorities, I can see the kind of commitments and the kind of action plan work. And apologies if I'm asking a kind of new attender question that everyone else knows the answer to, but have we got an outcome framework or something like that that sits alongside this in terms of being really clear what are we actually trying to change here for our population and for our citizens and for our patients, and how would we know whether we've made that difference to people against those areas?
Yeah, that's our sort of phase 2 of the work. So when the commitments were reviewed, one of the key questions we were asking is, can you measure success? Because what we didn't want is commitments in there that we can't evidence an improvement. And then this part, the phase 2, subject to approval today, would be focusing on then what are those specific success measures. So each commitment, the ask is that there is specific things that can be measured, both outputs and outcomes as well, is kind of where we want to focus. And that's through the development of then the performance dashboards, which will include a range of indicators. So it's going to focus on not just us as partners around a table, but also around the patient satisfaction or resident, depending on which term we're using, and their views as well. So I think all of it we want to encompass in the success measures.
Thank you. Well, thank you very much. If there's no further questions, then I will propose that the board approves the recommended changes to the current joint local health and wellbeing strategy 22 to 2032 as part of the current review, approves the approach to the next phase of the review, including indicative timescales. Do we have a seconder? All in agreement? Excellent. Item 9 is the Health Watch Leicestershire annual report, pages 217 to 232. This report summarises the activities and impact of the HWLL over the past year, and it will be presented by Fiona Barber, Vice Chair, Health Watch Leicestershire.
Thanks, Chair. Hopefully, Abby will be able to find the report and stick it up on the board for us. But firstly, thank you for giving Healthwatch the opportunity to present again its annual report. This report will cover the period from 24 to 25. It's a requirement of the Healthwatch that we do provide the annual report to the Health and Wellbeing Board, and it gives you guys an opportunity to run through what Healthwatch has been up to over the previous 12 months, and I'm going to hopefully talk a little bit about the impact we think we've had, as evidenced by talking to people, and also what we're thinking of doing for the following 12 months. And if you look in your pack, actually, we have the slide presentation in there. So even if it doesn't appear, and I'm sure there's a little person underneath the table whirring it like mad. That's lovely. Thank you. Next slide, please. So, yes, we're going to run through the purpose of Healthwatch. The reality is that Healthwatch was set up under the Health and Social Care Act all the way back in 2012. So we've had 13 years more or less of doing what we're doing. So we are set up under statute, and the only way we can be dissolved will be by statute, and I'll mention that later on. I'd like to touch briefly on the achievements of last year and then look forward to some of the stuff that we're going to be doing this current year, this current sort of 12-month period. And at the end of it, I think the board is going to be asked to note the report and the current plans. Next slide, please, Abby. The reality is, who is Healthwatch? Well, as I've mentioned, we are a statutory function. We are independent of providers, so we work alongside local authorities, the NHS, the voluntary sector, but we are very much our own people. We are jointly commissioned by Leicester City and Leicestershire County Council. The contract holder is my good friend on my right here, Voluntary Action Leicester. And we are obliged to hold regular meetings with commissioners from both the city and county who hold us to account in actually delivering the remit of our contract. Next slide, please, Abby. So we work very hard gathering data, intelligence and evidence, and we do that by going out and meeting people, talking to them, by holding surveys and trying to engage with as many different people from different communities in different places right across the county. The figures up there are indicative of city and county, but of course it's more or less a 50-50. So even the figures are more or less 50-50. So the percentage would say the number of people engaged, 53% are from the county in the last 12 months. And in fact, we engaged more people last year than we did the previous year and the previous year before that. So every year, the number of people linking into Healthwatch is increasing. And of course, the number of people coming to Healthwatch to ask questions, ask for advice or information, or be signposted is also increasing. This year, we've published more reports. We have a statutory obligation to carry out enter and view visits. And we also undertake subject reports. So, for example, I'll come on to the impact of those later, but if you're interested, then last year we carried out, for example, 24 enter and view visits. Half of those were in the county. All of those reports can be found online on the Healthwatch Leicester and Leicestershire website. They're all accessible. How do we pick an enter and view? Well, we do have a list. We work through invitation. There are providers who wish their services to have an independent rule of thumb run over them. There are intelligence and information that we get from members of the public, which lead us to say perhaps it would be a good idea for Healthwatch to go and have a conversation with people at perhaps a GP surgery. And as I say, the service providers do also ask us to come in, and CQC will also say, look, we've had some evidence, we're not due to go and see a particular care home for a length of time, but this evidence, does it match anything you have? And if there's a triangulation of intelligence, then perhaps Healthwatch would be the appropriate body to carry out an enter and view. All our enter and view visits are announced. They're done in agreement with the providers, whether that's a GP practice, service provider, or a residential or nursing home. We've been out and about in the communities. We go to a whole range of events, shows, pop-ups all round, and hopefully some of you will have seen us in your travels around the county. We hear a lot of stories, we ask a lot of questions, we ask people to take surveys with them. We also provide information, advice and signposting at those sessions. And this work is all carried out by a small team of employees. We have 7 employees supported by people who volunteer, like me. Last year, our volunteers provided just under 1,500 hours of support. That's nearly one full-time equivalent person, which is excellent news. Volunteers are advisory board members like myself, enter and view members, people who go out to community events as community support. And we also have a small number of Youthwatch members, people who are under the age of 25, who give us a very specific accent or view on health and care services. So what sort of impact does Healthwatch have? Well, we work in partnership with all the organisations sat around the table, excuse me, so you will all have a particular view on how you have been able to work with Healthwatch, how you've been able to be influenced by Healthwatch, and how you have actually delivered in conjunction with Healthwatch. So we actively sit on a number of strategic boards, both city and county. And for example, locally, I've mentioned some of the enter and view reports. Children and Adolescents Mental Health Service. We carried out an enter and view there last year at the Beacon unit. And at the end of the unit, there were 7 recommendations. So the volunteers, led by a member of staff, carry out a visit. They talk to people who are there as patients. We talk to people who are there supporting patients. We talk to members of staff, and we have a look with our own eyes what we actually see. And for example, those 7 recommendations come across a range of different things. There were elements around the food. As you can expect, food is always a touchy aspect when you're in as an inpatient. But there are also things about standardisation from staff and standardisation of practices across the range, and reducing confusion and hopefully improving aspects for patient experience, and also looking at how rooms are utilised, particularly outside of the ward, especially around school holidays. Little things like that, all pointed out by the enter and view volunteers, talked through with members of the staff there, who look at it, assess it, see what they think, and they come back with an improvement report. And then Healthwatch will go back after a few months and revisit and see what improvements have actually been made. It's a system which has been working well for a number of years now, and I think a number of service providers have felt that it is a useful use of their time to actually look at how patients perceive their services, the facilities they use, and then give them a hand to identify improvements that can actually work to improve the patient experience. We've also had input into policy development. We had a suicide prevention report that was used to support the work done on the suicide prevention policy last year, and the same again in dementia. There are loads of examples I could give, but we've only got a reasonable time today. There are plenty that you can see on page 6 of the annual report. We've broken them down by time of the year to show you what we've done and when. And there are also further examples as you move through the report. All the reports, we're very careful to highlight what works well, because it's very easy to sit there when you go into somewhere, have a look at a service and say, well, actually, that's not very good, is it? But it's important that we do recognise what works really well, because that information can then be shared, good practice or just really good impact on patients, alongside the areas where there are room for improvement, shall we say. So next slide, please, Abby. So what's happening this year? Well, as we've already alluded in the meeting to the decision by the Secretary of State for Health. He set out a clear vision, as Toby mentioned earlier, for the NHS moving forward. And amongst the future framework, Health Watch services, both at national and local level, are likely to change. By change, I mean they'll probably not appear in the current format that they are in. How's that going to happen? Well, to be fair, we've got absolutely no idea, because nobody's shared that with Health Watch England or Health Watchers yet. And I suspect that that's a work in progress in the Department of Health and Social Care. It does seem clear, though, from correspondence that we've had, that the Secretary of State does envisage patient voice being heard differently. At the moment, the inference is that the patient voice will be taken into local authorities and also into whatever version of the ICB appears in the next couple of years. And I suspect when we have details, then those will be shared. But as I touched on earlier, it will need an act of Parliament to decommission the current arrangements. In the meantime, you will hear from every Health Watch person, whether member of staff or volunteer, that it is actually business as usual until we are told differently. That means we're continuing to gather evidence, intelligence about the patient experience, and to make sure that it's shared with all the providers in a way that positively drives improvement for patients. Talking to people at the end of our last 12-month period gave us the information and intelligence that communities would like us to focus for the next 12 months on GP access, mental health and adult social care. So GP access, as usual, people are still whinging about their ability to access appointments when they feel they need them. So rather than focusing on that, because we've asked that question many a time and always get a similar answer, what Health Watch is going to do is look at where is it working well? Where is it that people are having a really good experience about accessing their GP services in the broadest sense? And let's look at that and see how that improvement and that good feeling can actually be promulgated across the practice as a whole. Mental health, again, lots of issues around wait times. We've done some recent work on mental health cafes, and what will spill out of that will also form a basis of working with LPT and other providers to look at how things can be improved for patients. And finally, the third key theme identified was adult social care. Now, this had us scratching our head a little bit because it's a new theme that's popped up for us from our perspective. And realistically, we need to understand why is it that the public have this on their particular list. So there's some work being done at the moment to try and understand what it is people are not absolutely happy with and what it is that we need to be having conversations about. So last year, we used a lot of Speak Up of events and surveys. I've already covered those. We will be doing the same thing again. If you're on our mailing list, then you will regularly get the newsletters that we send out with links to any surveys that you can help us with. And of course, if you're able to post those on, then that's really helpful too. So, as I said, business as usual until we hear otherwise. At which point we'll have to work with presumably local authorities and ICBs to make sure that we have a smooth transition. As all of us in the room know, that once you start introducing uncertainty into any organisation, then that impacts on the well-being of staff. So What I would say is that if anybody does have any information about the future of Healthwatch, please share it with Healthwatch first, so that we can have those conversations and make sure our staff feel valued and supported as we work towards whatever kind of transition that we're coming through to. We had this conversation at the City Board this morning, and the City Health and Wellbeing Board were understandably concerned about what direction this is taking, and felt that their chair would write to the Secretary of State expressing some of the issues. And I don't know whether the County Board wishes to follow that. But the basics are, we have no information, we're not sure what will happen, but like I've already said, Healthwatch will continue until it's told otherwise. So I think I've covered in a very quick snapshot the work of Healthwatch over the last 12 months and some of the issues that we're looking to work with this year. I'm very open to questions, Chair, if anybody's got anything or comments. Otherwise, the report is here for noting. Thank you very much.
Thank you. Well, I wouldn't know much about change in a large organisation. So any questions or comments? I'm not sure who was first. Was it yourself, Jean? No, Simon. OK. Yes, Simon, go ahead.
Thank you, Chair. And observation and offer. I just wanted to say thank you very much from University Hospital Leicester to Healthwatch for being a key strategic partner in the last 12 months and before. We really value the insight that we have received from the Children's ED review as well as from the adults the year before. I know our Chief Executive, Richard Mitchell, has met with Healthwatch and will continue to do so as we are in business as usual. As Fiona has said, we really value the insights that our patients via yourselves provide to us and are committed to making those changes. The offer is, so if we can be a better partner in the next 12 months and if there's anything we can do to improve our relationship, please do get in touch with me and I'll happily facilitate that within UHL. So thank you very much.
Yes, Jean Knight, please.
Hi, I'm Jean Knight, the Managing Director for LPT. So really sort of echoing what Simon was saying, we do absolutely value the involvement of Healthwatch, particularly for some of our young people, and really getting their feedback is incredibly helpful. Just a question really, in terms of some of the surveys you referred to in your annual report, where would we be able to access those? Because I can see the reports on the website, but I can't see any of the survey information. Just wonder if I'm looking in the wrong place.
I'm sure if you need any information behind the surveys, then we can provide that. If you let me know what you need, and we'll do that.
Toby Sanders, please, and then John Wilson.
Yeah, thank you, Chair. Two thoughts. Firstly, just to echo others' views around kind of the value of the work that Healthwatches do, not just here, but down the country. I think you provide a hugely important function. And the independence word that you use, Fiona, is important in this. You're not in any of these statutory organisations that sit around the table here, and that gives you a voice. I think it also gives you ability for other people to feel comfortable sharing their views and experiences with you in a way that they might be more anxious about talking to statutory organisations and being anxious about what that might mean for the provision of services and their care. So I think the hugely important role that you play when we recognise we've all heard the same national announcements in terms of potential change. I welcome it's business as usual. Certainly my steer and to my organisations absolutely is. Working with Healthwatch is business as usual. Nothing changes till it changes, and at the moment it isn't changing. So we carry on. On the forward look bit, welcome the focus on general practice access, but actually the slightly more nuanced approach into that. Too many of our residents and population still genuinely experience difficulties in accessing general practice, but at the same time we have, and many of our practices have made some real progress in innovations around particularly telephone access, particularly in terms of triage systems, particularly in terms of online booking and use of digital and tech in that space as well. So I'm sure you're connected to the LLR primary care teams, but anything that we can do to help in identifying some of those practices that we, and I'm sure also those practices, will be fascinated in what you might be able to identify in terms of experience from users in those particular services.
Yeah, thank you very much, Fiona. Thank you for the report. Just to really say, once you're a little clearer in terms of your focus for adult social care over the course of the next 12 months, we'll obviously be very happy to work with you and provide any information or scoping or any support that you need with that. and just to ensure that we've got as joined up an approach as we can have, because clearly we have our own improvements to make, and if there are things that you could add to that, that would be really helpful.
Kevin, please.
Thanks, Chair. It was just firstly an ask, but then also a plug, which it would be remiss of me not to plug. You know where I'm going to go with that one. The ask is really, as Fiona was saying, with anyone going through change like this, obviously staff do wobble. If you are receiving information yourselves in your own organisations about Healthwatch, can you please talk to us first before you go out publicly? Because we had a couple of situations when it was first announced of presentations being given by partners where there was sweeping statements being made about Healthwatch going, it was the death of Healthwatch and the other. And I had some of my staff sat in the audience then coming back probably in tears going back there, but that's not what you told us. So if you do get anything, please can you just let us know so we can sense check it with you and make sure that it is giving the right message out, because obviously, as Fiona was saying, it is still business as usual, but obviously we have got to be mindful there's a team there still not quite knowing what on earth is going on, because there's no guidance from central government about what the plan is going to be and how it's going to work. So there's that. And then I suppose the plug is there is currently a survey out at the moment, an extra piece of work we're doing with the ICB around Every Woman's Health Matters. So there's a huge survey that's gone out from Healthwatch. Gemma, who's the team manager for Healthwatch, is on a mission to beat a bet I've given her. She's currently at the moment had 3,500 responses back from individuals. She reckons she can get to 10,000. I said, do it, I'll buy you dinner or lunch or a drink or whatever she wants. So if you know of anybody basically who could complete that form and basically survey, it is for any age range of women, could be people who are just leaving school or whatever, please can you push it out. It is on the front page of the website there, so you can actually sort of go straight into it. So if you want to talk to your colleagues, if you want to talk to your people at home, family members, we would really like to get a broad consensus of understanding around health needs and matters for women around Leicestershire and Leicester. Thank you.
Thank you. Any other questions or comments? Okay. Well, I propose that the contents of the report be noted. So I can have a seconder. Thank you. All in agreement? Thank you. So we are just over halfway. So I think it'd be prudent to have a 10-minute break now and then resume shortly.
We're just getting the webcast going again, everybody. So 30-second warning.
Okay, welcome back, everybody. So the next item is item number 10, which is the Safeguarding Adults Annual Report, which is on pages 233 to 302. This annual report relates to the effectiveness of the work safeguarding adults and the effectiveness of the safeguarding adults in the local area. John Wilson, Director of Adults and Communities, will present the report.
Thank you, Chair. So I'm presenting the report today on behalf of Shona Douglas, who's the independent chair of the Adult Safeguarding Board, who unfortunately can't be with us this afternoon. The annual report is one of the Safeguarding Adult Board's statutory requirements. The board itself is established as a statutory body under the Care Act. There are 3 statutory partners: the local authority, the ICB and the police. But I'm very pleased to say that in Leicestershire, we also have the support around the board of a wide range of partners, all partners around this table. But in addition to that, we have prisons, probation, DWP, EMAS, fire service, so very, very wide ranging partnership. The annual report is one of the statutory duties, as I said, of the board, alongside publishing strategic plan and commissioning safeguarding adults reviews. They're the 3 statutory functions of the board. The business plan was presented to the Health and Wellbeing Board when it was commenced in October 2023. And today we're here presenting the new business plan for the next 2 years, which is part of the strategic plan that's been developed across Leicester, Leicestershire and Rutland. We present it here partly because of the wider partnership. There is a statutory requirement to present it to the leader of the council, Health Watch, and the chair of the Health and Wellbeing Board, but we present it here because of the wide partnership. Key messages for the board. The board will note that there has been a significant change in the proportion of safeguarding alerts which go on to become safeguarding inquiries. In Leicestershire, that was 46% during 23-24, and it's reduced down to 36% in 24-25. The reason for the reduction is not a reduction necessarily in the number of inquiries that we undertake, but it's an increase in the alerts. So it's a denominator numerator kind of an issue. Also noting that national data is likely will be published in probably November, December this year, and it's likely that the 36% will bring us much closer to the national average, rather than being at the sort of the top end nationally. One of the other things to note is that the board is now taking on a new area of work around rough sleeping. So there was I can't remember if it's a policy, I think it was a memorandum of understanding or some sort of policy issue from the Department of Health and the MHCLG, which asked safeguarding boards to look at people who are rough sleepers, and particularly if there are any deaths of people who are rough sleepers, that the board would undertake a similar process to a safeguarding adult review to ensure that there were no issues that we needed to pick up as a multi-agency partnership in terms of learning. In terms of priorities, there are a change to some of the priorities in the new business plan. So some of the existing priorities that we've been working on over the last 2 years will drop out, and there'll be new priorities that come forward. So those that are dropping out are self-neglect, not because it's not an important issue and not because it's not one of the main areas around safeguarding activity, but simply because we have had a focus on it for 2 years. We've developed new guidance, and we will be auditing the implementation of that guidance throughout the next few months. The other area that's falling out is mental capacity. That has been on the business plan now for a number of years, Again, it's one of those areas that is picked up consistently when we undertake safeguarding adult reviews. It's an area of continual learning, and we have done an awful lot of training over the course of the last 12 months. So it will continue to be a focus of work, but it won't be a business plan priority. Domestic abuse in older adults is one of the priorities that will continue into the new business plan, and it builds on some work that we undertook over the course of the last 12 to 18 months with Durham University on a research project. There was one safeguarding adult review published in the last 12 months, and there are 3 more safeguarding adult reviews commencing, which will hopefully be published within the next 12 months. So the business plan going forward has 3 new priority areas. One is equality, diversity and inclusion, another is timeliness and proportionality, and the third is impact of learning. And the new business plan is appended to today's report. Just in terms of resource implications, partners will note that expenditure has increased over the course of the last 12 months, largely driven by increases in salary costs. The costs of the delivery of the Safeguarding Adult Board now exceed the budget, but we are in a position where we have a reserve fund. So the position is that we are using the reserves rather than asking partners to contribute any increase in funding. We're going to use the reserves, and within the course of the next year, we will review the expenditure and the budget and ensure that we've got a sustainable position going forward. So I think, thanks, Chair.
Does anybody have any questions or comments? Siobhan.
Right, thanks for that, John. Just in terms of the domestic abuse in older adults, so the police force we've got a working group at the moment around that, because obviously from that Durham University report there are recommendations in there for police forces, and I'm not sure whether you were linked into that, and if you are not, would you like to be linked into that?
I'm not personally, but I think my colleagues will be in. I think colleagues in the authority are, and certainly it's a piece of work that's been taken forward jointly through the board subgroups. But yeah, it'd be helpful if you could just forward me something on it. That'd be really helpful.
Any other questions? Oh, Mike's hand, suppose.
Yeah, thanks, Chair, and thanks, John. Just to check, I think I know the answer to this one. The rough sleeping duty, or the homeless duty, that's just about rough sleepers. It's not unstable accommodation more generally, sofa surfers. It's just the count of rough sleepers in a particular year, is it?
I believe it is, yes. So it came out of a piece of work that was undertaken in the previous year, which suggested that there were people who were rough sleepers who potentially did have care and support needs, and therefore would, in normal circumstances, be subject to a safeguarding adult review, but weren't being picked up potentially because they weren't known to local services. So I think the requirement is that we undertake a process similar, might not be a full safeguarding adult review process, which can be quite detailed and quite lengthy. But they are asking that we undertake a similar process just to ensure that if there is any learning there, that we can pick that up.
Thank you. A question myself, actually. So looking at the data, it seems that there's a lot of repeat safeguarding concerns for the same individual. So is there any work that's being done to tackle the root causes so that we're not just kind of firefighting?
Yeah, certainly we do. As you've probably picked up in the report, we do record where there are multiple referrals for a single individual. Sometimes that's because of their environment. Sometimes it's because of individual risk issues. We do obviously, when we undertake an inquiry, part of the process is that we put a safeguarding plan in place. So we would hope that the plan would address the issues that were being raised. It's not always the same issue that gets raised with the same individual. It's not necessarily the same issue. But we obviously do look to put a plan in place that protects people. But there are people who are significantly at risk for multiple reasons.
Okay. If there are no further questions, then I propose that the board notes the Leicestershire and Rutland Safeguarding Adults Board Annual Report for 24-25, the Leicestershire and Rutland Safeguarding Adults Board Strategic Plan 2025-2031 and Business Plan for 2025-27, and takes into account the key points of relevance relating to health and wellbeing. Can I have a seconder, please? All in agreement? Excellent. So item 11, so we'll move on to the Safeguarding Children's Board Annual Report. This report's on page 303 to 378. And this report details the effectiveness of multi-agency arrangements for safeguarding children. Gary Watts was going to present this report, but he's now unavailable. So I'm going to ask the board to note the report. Unfortunately, we won't be able to take any questions today, but we will pass them on to Jane Moore and we'll answer them outside of the meeting. So therefore, I will propose that the Leicestershire and Rutland Safeguarding Children Partnership yearly report for 2024-25 is noted, and the Leicestershire and Rutland Safeguarding Children Partnerships business plan for 2025-27 and the key points of relevance relating to the health and wellbeing are noted. And I have a seconder. Thank you. All in agreement? Thank you. Agenda item number 12 is the Better Care Fund Quarter 1, pages 379 to 394. This report sets out the Better Care Fund performance against key metrics for Quarter 1, 25-26. Lisa Carter, Health and Social Care Integration Service Manager, will present this report.
Tracy's just going to introduce it and then I'll take it from there.
Good afternoon, Tracy Ward, Assistant Director, Information Advice and Prevention. I'll just take you through the recommendations of the report and the policy framework and previous decisions. So it's recommended that the performance against the Better Care Fund outcome metrics and the positive progress made in respect of transforming health and care pathways in Quarter 1 is noted by the board, and that the action taken by the Chief Executive of Leicestershire County Council to approve the Better Care Fund Quarter 1 report and the use of delegation to approve this for NHS England submission was agreed at the deadline for the 15th of August. So just in respect of the policy framework and previous decisions, nationally the Better Care Fund for 25-26 for Leicestershire was officially approved by NHS England in June 2025. So I'll now hand it over to Lisa to take you through the content of the report and then we'll take any questions.
Thanks everybody, thanks Chair. So the Quarter 1 template for the BCF for 25-26 has changed slightly from previous years. Previous years it's been a bit more comprehensive and has included things like a review of demand and capacity. This year it's been kind of pared back a little bit and it's now inclusive of just an update on a few areas of work around income and expenditure. It did give us an opportunity to review any of our targets against the 3 key metrics within the Better Care Fund, and it gave us an opportunity to update on the national conditions. Just with National Condition 1, there's a condition to actually have the Section 75 received here today, which will be following on from this report. So that meets all of our statutory responsibilities around those national conditions. That was the only thing that was currently outstanding. For Quarter 1, we don't actually have the Quarter 1 actual data. So what we've done is we've actually just applied Quarter 4 from 25-26, and that's because there's a lag of national reporting for these indicators. At the moment, we did take the opportunity to amend slightly a couple of indicators, the first one being the rate of admissions per 100,000 population. It didn't actually affect our overall target, but just meant that some of the month-by-month individual targets throughout the year were slightly changed, just based on the fact that we had got some additional data from Quarter 4, which allowed us to make a more better representation of where we would be
as a like-by-like comparison in quarter 4 of 25-26. So that did change slightly. Quarter 4 had a target variance against our quarter 1 of 0.057%. So we're pretty happy that we're on target with that one. The target was not revised for the average length of discharge delays. Quarter 4, we are performing 0.5% off target. So we're not too concerned about how we compared with quarter 4 from last year to what we've got for our targets for this year. We are taking slightly longer than we had wish we would be in quarter 1, but we're still kind of in line to make sure that we hit our target by the end of the financial year. In terms of long-term support needs for people over 65 admitted to residential nursing care, that is also pretty much on target for where we expected to be at this time of the year. So again, no concerns raised there. We have got some updated spend and against activity, and that is part of the report. We have published in our expenditure that we've roughly equated to 24% of the spend, and we'd expect it to be around 25% of the spend, it being quarter 1. As part of the report, you'll find attached the template that we had submitted. And so Tracy said it's just recommended that it's noted and that the actions of the Chief Exec to use powers of delegation to approve that were taken for the deadline.
Thank you. Are there any questions around the floor? Kevin, please.
Just a quick one, Lee. So you're saying obviously there's been a lag. Is that expected to continue? Have you been given any sort of guidance about when they might be able to bring things back in line for you?
No, it probably will continue. So it's national NHS England data that is variously published throughout the year. And when I say there's a lag, it's just a lag for the full quarter. So at the moment we're looking at July data, but of course it's not the full quarter. So it's not always completely comparable. So what we do use is the quarter previously, check that against what we projected in the 24-25 plan to ensure that we're pretty much in line with our targets as we expected them to be.
Thank you. A question from myself. The quarter 1 figures show pressure on hospital discharge. So what's the plan for increasing domiciliary care capacity before winter? Because obviously we're getting fairly close now.
So in terms of the discharge metrics, they don't just include pathways 1 to 3, they also include pathway 0. So it's everybody that's leaving hospital. The majority and the bulk are people who don't go on to receive domiciliary care. So we're looking at around about 15% of people on any given week leave into a service like domiciliary care or reablement or residential care, whether that be permanent or temporary. So as part of that, the domiciliary care, it forms quite a small percentage of people that leave hospital every week or month or however we want to measure that. In terms of domiciliary care, we actually try and increase our capacity around reablement, because reablement offers people a much better opportunity to recover from a period or spell in hospital. But at the moment, our wait times for domiciliary care, we don't really have any wait times. So pretty much the minute we receive the request for a plan from UHL, we actually provide that plan ready to start within sort of a day or two. And generally we'll have been to see people on the wards to make sure they don't have at that point any reablement potential, which is why we're recommending a package of care. So at the moment we don't have particular delays for packages.
Okay, thank you. And I noticed we're spending quite a lot, millions through the pooled budget. Is there any evidence that is delivering better outcomes or is more efficient than if each organisation spent separately?
Well, I think you're always probably going to get better value for money when you do things collaboratively and collectively, particularly with things like, I think we've got two elements of pool budget, haven't we? We've got the LD pool for learning disabilities, and we've also got pool budget around heart reablement. And that's much more better managed and gives you greater capacity if you do that collectively, as opposed to individual organisations commissioning that on our behalf. And it also gives us a much better way of standardising our outcomes. So, for example, there are some areas up and down the country that do commission reablement from the private sector, but actually we get better outcomes, and that's been proven because we used to do it that way, and so we now can get better outcomes by having that as an in-house service. The same applies with LD pool, which is the other pool budget, which actually helps to support people and get them better outcomes by having a more, I suppose it's a more personalised approach, so for independent housing, etc. So yeah, I would say that it does give us those better outcomes.
Great, thank you. Is there any other questions or comments? Rachel Jur, please.
Yeah, just a comment related to your question about winter planning. Over and above the BCF work that's happening, I can give absolute assurance that the local authority have absolutely stepped up in terms of the additional support that they can give through the winter months, in terms of how we will work collaboratively and how we will make sure that we've got really good flow through our system. So I'm really assured that not necessarily always related to the BCF, but in terms of the winter planning, particularly impressed this year by the local authority coming forward and saying, and we can also do this as part of the risk share.
So hopefully a empty A&E this winter.
Sorry, just to pick up on what
yeah.
Rachel has spoken about as well, is we're part of a extended pilot with Newton Europe, so free engagement to look at both step up and step down services. Rachel and myself and Taz from the ICB are part of that network. So the next step in relation to that is tomorrow, and it's also looking at what it kind of quick wins in relation to that. So we'll feed that back in respect of intermediate care and other things.
Simon, please.
Thank you. I think Lisa and colleagues can attest to the questions that I drive around value from the Better Care Fund, and that we put in, obviously with financial challenges across the system, we want to ensure we drive value from the Better Care Fund, and I am a frequent advocate of asking those questions. And I think I've got significant assurance that we are driving value from our Better Care Fund by working together. One of the examples over the last few years has been the ability to share roles. So regardless if you're in social care or if you're in health, the patient or the individual has a need in front of you when you're visiting them, and we're able to now fulfill that need without having to wait for the next professional to make an additional visit, coming at an additional cost. That's just one of the examples of the changes that the Better Care Fund has driven, which is better quality care for patients, but also better financial value for all of us in the room. So I do ask that question on a regular basis, and I think it's a really important question, but I am given the assurance that we are delivering value on that pool fund.
Thank you. Any further questions or comments? Yes, John Wilson, please.
Thank you. Yes, I think Better Care Fund itself is obviously under Section 75, and therefore the whole of the fund could be viewed as a pool. Going back to Simon's point, really, one of the advantages of that, I mean, clearly it's a statutory requirement anyway, so we are mandated to put certain amounts of money in from a local authority perspective, and we're mandated to put certain amounts of money in from an NHS perspective. But one of the benefits of having it in the Section 75 is that it does predicate what we spend that money on to a degree. So it does mean that as a partnership, we have to spend the money, or a certain amount of money, on intermediate care. We have to spend a certain amount of money on protection and social care services. We have to spend a certain amount of money on community health services. And that's quite helpful, actually, because as you're quite aware, if you're a county council or if you're an NHS organisation, there are so many calls on your finances, there are so many pressures on your funding, that it's very easy sometimes to decide, well, we need to spend it here today because this is where our current pressure is. Having it in the Section 75 means that that money is protected for those purposes that we as a partnership have agreed are important, and so there are some benefits to having it in the section 75.
Okay, so if there's no further questions, I will propose that the board notes the performance against the Better Care Fund outcome metrics and the positive progress made in transforming health and care pathways up to Q1. The action taken by the Chief Executive of Leicestershire County Council to approve the BCF Q1 report and use of powers of delegation to approve this for the NHS England submission deadline, 15th of August 2025. And can I have a seconder? Thank you. All in agreement? Agenda item 13 is the section 75 agreement, pages 395 to 478. This report presents the refreshed Better Care Fund section 75 agreement for 25-26 and seeks approval to continue with the pooled budget arrangement. This report will be presented by Lisa Carter.
Thank you. And I think I make the same statement every year. I don't propose to go through the whole section 75 agreement, but instead I'll just summarise some of the points made in the cover report. So the purpose is, as usual, to refresh the section 75 for this financial year and to seek approval with that continued pooled budget arrangement. The work has been done collaboratively with the ICB. This year we have taken a slightly different approach, and all of the section 75s have been drafted in a very similar way across LLR, so that gives us a really good level of continuity against those section 75 agreements for a pooled budget. It's recommended that it be noted, that work, and that the continuation of the section 75 arrangement is approved by the board. So as part of the policy, we have to have that in place, as what John was, as John was just highlighting. It is a legal requirement for us to have a section 75 that sits alongside the Better Care Fund, which allows us to pool that money into one single, as I like to call it, bank account that we can all work from and commission services from. So it takes away some of the bureaucracy around doing it all independently, which I think, Chair, goes to answer some of your question about the differences that can be made from having it pooled in this way. There are contributions to the operation and management of the pool budget. Eligible service users are included in this agreement. The County Council and the ICB's roles and responsibilities are also highlighted, along with scopes of the services that are provided within that partnership, and that we have a duty to review the governance arrangements that surround it. Currently, obviously, it is signed off by the Health and Wellbeing Board. So as part of the Section 75 agreement for 25-26, which is attached, the agreement underpins the plan that is approved by NHS England that we submitted, as we discussed, in June 25 this year. So that's our current plan. The updated agreement continues to have focus on the financial risk sharing, and that the BCF will continue to operate within its own resources and not place additional financial pressure on either the County Council or the ICB. I've highlighted some of the key changes from the previous report. Some of those are around the resource implications. You can see that there's an updated expenditure, which is 84.4 million. It is supposed to say at the top of point 14, 25-26, not 24-25. But it shows you the breakdown at point 14 of the individual elements of that section 75 funding that's pooled. There are two elements of what we actually do refer to as pooled budget, which is around the heart reablement and the LD pool, which is also listed in that section 75. And that's it from me.
Thank you. Any questions? Just me then. So 2 questions. Does the agreement give flexibility to reallocate quickly mid-year or reprioritise if needed?
Yeah, so the section 75 is an agreement for us to have that pooled budget so that it is a much more simplified way of being able to spend what is joint funding. John's right, it does come with, you know, central government mandate to have a certain proportion and element of that attributed to adult social care services. But what we do within that actual budget itself can change mid-year as we see fit, really, and as we agree to as we go on. So, you know, it's just mandating that we pool it in one area, not mandating what or how we spend it on, with the exception of those funds that are detailed in there around the LD pool and the heart reablement, which is what we described sort of separately earlier. So that has got a bit of a mandate around it. What we can't change is the percentages of allocations that unless that is over and above what is mandated by government. So we can't, for example, at the moment we have a certain amount that has to be provided to adult social care from the ICB. We cannot make that less than it is. We can make it more, but we can't sort of change that to make that less than what's been mandated as a certain overall percentage of the BCF, if that makes sense.
Yes, my final question was, how would the board be kept informed and variance, or if there was a significant unforeseen overspend before it became a crisis potentially?
Sorry, I missed the first bit of the question. Before the overspend became a crisis?
Yes, how would you keep the board informed if there was any predictable or perhaps unpredictable overspends before they were to become a crisis?
Well, in 10 years, we haven't done that yet. So, but we do report quarterly, and every single part of that quarterly reporting does have the element of financial spend against activity. So it would be really a real surprise to us if there were any overspends. What we also do is through the integration exec, we do report quarterly on any areas of huge variance in spend. And then we do pre-allocate that sort of around if we know when we're going to have any underspends. It's never really particularly overspends that we can't adjust mid-year. But if we do have areas of significant underspend, we do reallocate that as we go along. So there's a constant financial management of the overall spend.
That's probably how I should have worded it. Okay, any further questions? Yes, Toby Sanders, please.
Yeah, thank you, Chair. Clearly a really mature set of arrangements here, as you say, that over the best part of a decade have kind of established themselves, and I can see that written through. So fully supportive of what's here as one of the signatories that will go onto those documents. It's just a thought really looking further ahead. We touched earlier on in the meeting around neighbourhoods and around the focus on kind of neighbourhood health and ways of working. We also touched on future roles in terms of integrated care boards and moving to a bigger, more strategic geography. I'm going to be really interested over the next couple of years from an ICB perspective on where we can go further in terms of tailoring some of the work we do at a neighbourhood level in terms of some of the resource that's in this kind of space, but also exploring with other partners, particularly local authority colleagues in this room, what other opportunities might there be for us to look at making better use of our resources, clearly in a managed and controlled way where we understand risk, where we understand the kind of joint benefit of that, but that places more focus on the geography that you focus on here at the moment in this kind of current configuration. Similarly, from a Leicester City perspective and a Northamptonshire perspective, what I don't want to be doing over the next few years is leading a set of integrated care board arrangements that just draw everything up to an enormous geography across the whole of Leicester, Leicestershire, Rutland and Northamptonshire. And so just a marker to say really keen with colleagues in the room to explore where else we can go in terms of alignment with neighbourhood services, but also potentially in terms of some of those joint and potentially pooled arrangements around commissioning areas as well. I'm not looking for an answer in the room today to that, but acknowledgement that I'm going to be keen with the new exec team to look at how we do that.
I think we could probably give you assurance for that, Toby. Sorry that you weren't looking for that, but to be honest, every year we kind of slice and dice the BCF to ensure that we have got the vast majority of the funding aligned more to preventative and community developments. Currently, we're looking around 70% of our BCF is purely focused around the delivery of community services, with the rest split between intermediate care, and then there's a very small amount actually that's aligned to acute care. So we can already give you those assurances. How we slice and dice that within the community services is very much aligned to both that neighbourhood plan, but also the joint health wellbeing strategy. So if you look through our delivery plans against the BCF, they're all aligned to the previous priorities, because we haven't realigned them yet to the new ones, but they're all aligned to the previous priorities. So we can categorically say this is how we are delivering against those and utilising our BCF to do that. In addition, we also have a Chloe document for every line of the BCF that tells us where that money is being spent. So we have assurances about the potential for outcomes in each of the areas. It's kind of mixed, and we do refresh it every year. And we have got a proposition that will go through the integration exec to have a workshop in sort of January to go through the BCF again as much as we can, because we won't have any national direction by then about what to do. But to make sure that we've aligned it all to our kind of policy and the things that we've committed ourselves to. So actually we can give you assurance.
Oh, excellent. Any further questions or comments? No. Okay then. So I will propose that the board notes the work undertaken to refresh the Section 75 pooled budget agreement for the Better Care Fund, and the continuation of Section 75 pooled budget arrangements between Leicestershire County Council and Leicester, Leicestershire and Rutland ICB be approved. May I have a seconder, please? Thank you. All in agreement? So our final report is the annual health protection report, pages 479 to 514. This report provides an overview of health protection activities in Leicestershire. This report will be presented by Anuj Patel, Strategic Lead Health Protection, Leicestershire County Council.
Thank you for having me here. I'm Anuj. I'm a Strategic Lead Health Protection at the County Council. So the purpose of the report is to provide the Health and Wellbeing Board with an overview of the various health protection activities that have taken place over the past 12 months from January to December 2024, as well as to give an update on the performance of the health protection system where appropriate. Health protection is the process of safeguarding populations and individuals from infectious diseases, environmental hazards and other public health threats, including emergencies. And this report supports the statutory duties of the Director of Public Health and aligns with key local health strategies. So we're asking the Health and Wellbeing Board to note the Health Protection Report for 2024 and to recognise the health protection issues that have arisen locally and the steps taken to deal with them and the areas of focus for 2025. The first domain of health protection that's covered in the report looks at outbreaks and communicable disease. COVID-19 is the first one of the report, and we can see that vaccination still remains a vital tool to help control COVID-19 and reduce the risk of ill health, particularly in those that are at higher risk and worse outcomes from infection owing to age, existing illness or other vulnerabilities. The next communicable disease looked at is measles. In January 2024, almost 3,000 cases of measles were reported in England, bearing in mind England was previously a measles-free country. Over the summer of 2024, there was an increase in measles across the East Midlands. We'd noted a downward trend in MMR uptake, and in mid-2023, a local measles elimination group was established as a proactive measure, and NHS England released their vaccination strategy in December 2023, which highlighted similar concerns of a decline in MMR uptake. Whilst to date measles cases in the county remain low, proactive and preventative measures continue to be implemented. 15 measles cases reported in Leicestershire between the 1st of January 2024 and the end of the year, but as cases were identified, proactive steps were taken to offer vaccination in areas at risk, and an MMR call recall campaign of to vaccinated children was carried out between February and March of 2024 as the second phase of the national catch-up campaign, building on activity that GP practices had undertaken at the end of 2023. For Mpox, the World Health Organization had declared an upsurge of clade 1b Mpox in a number of countries in Africa, but the risk to health in the UK remains low. Pertussis cases, also known as whooping cough, is a cyclical disease, and we saw an increased number of cases reported throughout 2024 above the expected seasonal norms. In response, to the national increase in cases, an incident management team was convened, chaired by our Director of Public Health, and our key strategies focused on improving maternal or antenatal vaccination rates to prevent infant hospitalisations and deaths, as well as timely and complete vaccination for infants and children under 10 years of age. There have been reports of highly pathogenic avian influenza in the country in 2024 amongst wild birds, but the risk to human health remains low and surveillance remains ongoing. Immunisation performance for childhood immunisations is given in the report as well. Coverage for Leicestershire exceeds the performance for all child immunisations compared to the England average, but data shows a national decrease in children receiving their routine immunisations, and that's been ongoing since 2019. At the start of 2024, an LLR immunisation board was established, and that brings together key system partners to oversee the delivery of vaccinations across the county. And we've got the HPV vaccination uptake data there. In September 2023, the HPV vaccine programme changed from a 2-dose schedule to a single dose for eligible adolescents and men who have sex with men who are aged under 25, as advised by the JCVI. For tuberculosis, nationally for the year of 2024, provisional data saw an increase in TB notifications by 13%. Overall, notifications rose from 8.5 per 100,000 of the population to 9.5 per 100,000. England remains just below the threshold for the World Health Organization to declare as a low incidence country, but TB rates remain low across Leicestershire. A new vaccination programme was launched in 2024, protecting eligible people against RSV. So the eligible cohorts are pregnant women, those aged 75, and there was a one-off campaign for people aged between 75 and 79. The antenatal programme is being delivered by UHL, and the programme for older adults is being delivered by primary care. Performance for cancer screening programmes is given in the report as well. We saw a downward trend observed nationally and locally for cervical and breast screening. However, this still is a better than national average for the county, but bowel cancer coverage seems to improve year on year, and that's being noted nationally as well. Sexual health key performance indicators are given. Leicestershire Public Health Commission the integrated sexual health services, which detects, prevents and treats sexually transmitted infections in the local population. The emphasis remains on self-managed care whilst preserving the quality of testing, results notification and partner notification. For Leicestershire, the main site will be delivered from the Loughborough hub, and that's going to be supported by outlying spoke clinics across the county. And there's an online service as well, which commenced on the 1st of April 2024, offering a range of testing options for STIs, treatment for chlamydia. Online service access has increased since the pandemic, and this service enables those in more rural areas to access the service as well. Given the performance of the healthcare associated infections, so LLR trusts continue to investigate alert organisms, and they conduct post-infection reviews, root cause analyses when required, and they cascade the learning outcomes to the relevant teams, the public health IPC teams, and we conduct reviews of C. diff cases within care homes where necessary. If learning outcomes involve general practice, the ICB IPC team, they support communication and escalate actions where necessary. Moving on to emergency preparedness, resilience and response. We engage with the local resilience forum to undertake the scheduled exercises or to participate in them. A number of exercises are planned for 2025, which includes national exercises. And member organisations maintain effective health planning arrangements for emergencies and incidents. In terms of air quality, we know that the health risk is disproportionately impacting some groups of our populations, for example, children, older adults, people that are pregnant and those with long-term health conditions. Inequalities in air quality exposure, such as social deprivation, and the new air health quality needs assessment was published in 2024 and recommended 7 areas for action. But to conclude, I hope our DPH remains assured that systems are in place to satisfy its duties.
Well, if I finish off, thanks, Anuj, for the report. Just picking up on your point, and I suppose the two of us, I'm very grateful to you and colleagues for putting together the assurance report. I know it's my assurance duty, but I suppose the reminder is that I also want to bring it here because we're a health and wellbeing board and health protection is an important part of health and wellbeing. So am I assured as much as you can be, because you never know what's around the corner, normally at 4 o'clock on a Friday afternoon is one. But I think we have got the process in place. It does give me a chance to say thanks to a variety of partners, particularly NHS partners, for the work around screening, vaccinating. There's a load of stuff in there, which I know we've presented it as a health protection report to assure me, but it's very much a system response to the nasties and the unknowns that Anuj has flagged. There was a couple of specifics I was just going to flag. I was thinking measles, you're right, 15 cases of measles. More than I would wanted to have seen. Obviously, the city had a large number. I was going to say, Anuj, I don't think we had an outbreak as such within Leicestershire of any particular note. It was more dealing with kind of cases where people have been exposed either in the city or in the West Mids was one. And then TB, again, we remain low prevalence within Leicestershire. And again, you know, it's not to blame City, but nonetheless, it is a fact that the city's got the highest rate of TB in the country. So the work that we have to do with our city partners and across LLR and across the health system to tackle, you know, it's one of those ones. If we don't tackle tuberculosis in the city, then it's going to affect the whole of LLR just because of the spread. So, so there's a few things in there, one of which is grateful for the work. I think the process we've got in place give me as much of the level of assurance as we can. Grateful to the work of partners, but there are a couple of specifics in there where we can look at the headline figures and go, yeah, okay, but actually it says an awful lot about the good work we do that has kept that kind of threat level in the county at a kind of reasonable level. So thanks, Anuj.
Any further questions? Yes, people know.
It's just for Mike, really, as we head into the autumn winter period and vaccination season, what your view is, as it's a public meeting, on the importance of having both members of staff in health and care and members of the public having their COVID and flu jab, really.
It's one of those ones. I thank you, Pete, for the question. Obviously, I'm not going to say anything other than we really need to get those rates up. Let's do the not so nice bit first. We've got a challenge with our staff vaccination rates, I think both within social care, within the NHS. So it is a public meeting, you know, whatever there is, we were just having a conversation about vaccine hesitancy. And I think one of the things, you know, the focus is on at the moment is actually it's not so much vaccine hesitancy, but those are a little bit hesitant. If you don't make it easy for them to get a vaccine, it makes it easier for them not to bother. So the more we do put the effort into thinking about how do we make it easy for our staff and how do we make it easy for the public to access vaccines, the better. I know people like Annie Trainer within the ICB have been really good at pushing for the kind of mobile vaccination vans. Anything we can do in terms of the plans of the ICB, Neil's been very supportive as well, I know, at Clinical Executive, to make it easy. So there's always going to be work around hesitancy we need to address with certain populations, but I think it's one of those ones. That focus on making it easy to do the right thing is the bit that we need to get right, but we do need our staff and our public to engage with us and take up the offers that are there. Because we talked about winter preparedness and BCF and variants against BCF and hospital admissions. But that, what's the one thing that we can do that doesn't cost an awful lot that will make a big difference to the health of the population and choke off admissions to A&E? It's good vaccination coverage. So, we could do a whole bit about the specifics of the plans we've got covering, but it is that time of year when we need to start getting that message out to staff and the public that this is what you can do for yourself, and it also helps the system as well.
Okay, any further questions or comments? Okay, well, thank you very much, Anuj, and makes sense. So I'll propose that the board notes the annual health protection report 2024 recognises the specific health protection issues that have arisen locally, the steps taken to deal with them, and the areas of focus for the coming year. Can I have a seconder? Okay, all in agreement? Excellent. Agenda item 15 is the date of future meetings. Future meetings will be Thursday, the 4th of December 2025, Thursday, 26th of February 2026, Monday, the 15th of June 2026, Thursday, 17th of September 2026, and Thursday, 10th of December 2026. So a lot to look forward to.
Got a haircut.
You got a haircut that day, haven't you? We'll have to rearrange.
Which hair? Yeah.
Right. So agenda item 16, any other items with the chairman has decided to take as urgent? There's no urgent items. So thank you very much for everyone attending Health and Wellbeing Board. It's been very enjoyable and enlightening, certainly better than the first one. This is my second time. So I'll draw the meeting to a close. Thank you very much.